we should start by, I hope everyone had a wonderful night's sleep today. And today we're going to be really focusing on a specific aspect which of sleep, which is how we can monitor and how we can report it to the doctor or the clinician that follows you. But before that, we do want to give you a glimpse of, let's say, how people are being challenged by sleep at this moment.
So we went through the survey, and there were so many responses that we just went through each piece of it, and it's probably worth reading each one out loud, just because you'll see some patterns. But just like Parkinson's, there's a lot of variability. So someone talking about leg cramps, a dystonia perhaps, it's pretty common. Getting to sleep, so that might be falling asleep rather than staying asleep. Waking up in the middle of the night and having trouble falling back to sleep. Probably one of the most common things we ever hear. It's very, very prominent in Parkinson's. Back and leg pain, I get back to whether this is dystonia or something else. And then waking up or 2 or 3 a.m. and probably not getting back to sleep very, very quickly. That's another very common one, and there's a couple reasons why that can happen. Going to sleep okay, then waking up too many times through the night, and the CPAP, that's the mask you wear for sleep apnea, is not helping. Ache in my right leg or ankle wakes me up and I struggle to get back to sleep. Again, that's probably an off-period focal dystonia or something. A couple times a week I wake up around 5:30 or 6 after going to bed, no later than midnight. So maybe early rising, and then of course once you're up, you're up. Waking and not being able to fall back asleep, again, that's probably one of the more common. Nocturia is a fancy term for having to get up and go to the bathroom in the middle of the night. 3 or 4 bathroom trips per night, that's a lot. I have REM, sleep behavior disorder, and sleep apnea. So RBD is when you act out your dreams, and the sleep apnea obviously wakes us up. So I have to sleep alone in a room that has been made safe, prepared so that if you fall out of bed, you don't get hurt. REM sleep disorder and hitting my husband. Again, that's that REM sleep behavior disorder is RBD. Waking up way too early. I average about 4 hours of sleep per night. Fragmented sleep. That's a similar issue that we were talking about before. I can get to sleep, but I wake up multiple times. Waking up to go to the bathroom and sometimes after dreams, probably vivid dreams. That's very common.
Yes, so that gives you, I would say, a glimpse of how sleep might impact the participants that are here with us in the talk. So instead of being general, it's just what people reported to us. And this means that what we are going to be focusing on, okay, so why should we think about monitoring and reporting these issues? And then if I convince you that maybe it is relevant for us to monitor, okay, so what exactly should we be monitoring? And the next step is, how do I do it more effectively? And that is it translated into something significant. So these why, what, and how was really based on that feedback that we get in terms of the challenges that you felt. So the why is usually like not knowing. Let's see, I can. People reporting that they don't know the relevance. Why should I be bothered to do this? And then also trying to understand what exactly should I be reporting or registering is comments like not knowing what the doctor needs to know about this. And another person said, I started once and it's up for 2 weeks, but no insights came from it, and I couldn't keep up the dedication to stick with it. So it does show us that you need some sort of resilience, and if we are going to take the time to register something, it really has to translate into something. So not knowing what to track is one of the things that will probably influence why we do it as well. And then we have, okay, so we might have limitations in how to do it. So if I really don't, what type of, I would say, devices, tools, and strategies can I use to report it? So you'd have people say, I usually remember, but probably it would be more advantageous for me to keep a record. Remembering to keep a sleep journal is sometimes challenging. The person doesn't remember to track it. Another person said, I feel that I have a pretty good handle on reporting sleep issues because I've had it for so long time, which kind of like shows us if you're probably dealing with the problem, you are already reflecting on how you should be doing it. And then we have issues as well that will also bring some barriers like handwriting and time as well. So this was the basis. And so shall we start with our first question, which was why should we bother to monitor and then transport and report what we monitor to the doctors? And I think the first important challenge of thinking that we gave was, is it beneficial for people to be monitoring their symptoms without having complaints? If we think about Parkinson and the complexity that it has so many symptoms. So we can only imagine if you were monitoring absolutely every single symptom, how quality of life would definitely be affected by this. There would be no time for anything else. And so I think if we choose key symptoms that make, I would say, some sense and that are significant for you to be able to manage Parkinson, because I'm guessing that is the ultimate goal, is how can we keep Parkinson calm and well managed and medicated and doing the things and strategies to keep it well, to keep yourself well. So as we ask people, yes, some people do, yes, I believe monitoring even without complaints could help me identify problems early. This was the majority. And then, but again, we kept this question in because there is also significant amount of, I would say, defining should we or should we not monitor this, why? So coming back to our why, I think the first argument that I would use is sleep is probably one of the most important symptoms of Parkinson that has a major impact on all the other symptoms. And nowadays, people already associate sleep problems with Parkinson because we have all these educational programs, so it's wonderful to see the impact of that. But before, all these non-motor symptoms, people wouldn't associate to Parkinson, so they wouldn't even report it to the doctors. So I think that's why it's important for us to participate in these type of educational programs and get to know, because knowledge should not frighten you. It should help you manage better the disease. So trying to convince you or at least recommend that this is an important topic for you to monitor is the impact that we know that the lack of sleep or deficiency in sleep can really make people have worsening of motor symptoms. So you'll feel slower, the rigidity will be impacted, your balance will impact. And I'm sure everyone feels when you have a very bad night's sleep that the whole day is affected the next day, right? There is also already some research suggesting that it influences also how we cognitively function. And also if we are, it's linked to higher levels of depression and anxiety. So if we are not sleeping well, we are probably going to be, I will use the word not very clinical, a little bit more cranky the next day, right? Cranky is a good one?
Yes, fine.
But tolerant would probably be the right word. And obviously we will be suffering during the day with daytime fatigue and sleepiness as well, which would make it really difficult for us to engage in the activities with the right mood. Now, I put others here because there's a lot of research in this area. It's fascinating. You have congresses of 4 or 5 days only on sleep, so it's a complex phenomena. And there's a lot that we still don't know how sleep affects human activity, I would say, not only in Parkinson, but in general. But so hopefully it is important for us to think about that maybe some symptoms of Parkinson, like my gait, my sleep, the way I'm thinking, so the cognition, are probably the top 3 that come to my mind now that would be important for people to monitor. And this one of sleep, specifically, it allows you to detect problems early on and to act on it. Sometimes people might feel dismotivated to track things because maybe the response that they get or the treatment might be insufficient or disappointing, right? But we do have solutions for sleep, and hopefully we can share some of them with you today. What commonly would happen is you would go to your neurologist and you complain about sleep, and he starts thinking about this thing pop in his head. He's thinking, okay, Maybe this is a process of degeneration. So there's something happening in the brain that might cause sleep. We do know that people will have changes in sleep before they are diagnosed. So it's actually one of the symptoms that is predicting almost the development of Parkinson. It's highly linked as a risk factor for Parkinson. But we do know that people throughout the progression of Parkinson, they might have the problem and not have, and they manage it better. So it's not like it's accumulating symptom, right? You can manage it and you can have periods without difficulties.
I would say that if you manage it early on, if you can track it and find it, just like a lot of other symptoms in Parkinson's, you can be more effective because you'll build those habits and those patterns early on.
Yeah. And then obviously doctors tend to think a lot about medication. Obviously, that's our main function. So things that they can change, they can control with the pharmacological interventions. So thinking about maybe medication that either can be bringing on these problems and how medication that maybe can handle it. And then in Parkinson, it's very important when we distinguish, is this just a sleep problem or is it related to my Parkinson? And this is where the rationale of on-off phenomena, which means either your body is having a good response to the medication and the doctor might prescribe you something at night so that you can have some dopamine level during the night. So it is more complex than just having sleeping issues. We have to put into the equation the changes that Parkinson causes as well. Of course, I would highlight that the most important thing by reporting these issues, even if you think, maybe this is not important for the doctor, but the truth is it might help identify effectively reversible causes. So that means the doctor, because he will connect the dots of the problems with the complexity of the disease that it's impossible for you to know everything and to be able to connect them. And he might help you tackle the problem. So imagine you have a behavioral issue that you maybe never thought about. The one I think is one that people don't often think about is after dinner, what people usually do is they go sit on the couch. Well, if you're a woman, maybe you go wash the dishes. In my country.
Good, yes. Well said.
So you go and usually people will sit down and they actually winding down, right? Because they head into the night and to sleep. And so they might fall asleep on the couch. And you get into this very deep state of sleep. And then when you go to bed, some people have much more difficulty to fall asleep or staying awake then, right? So it's sometimes this behavioral. So if we are able to do something that will allow us not to have that deep sleep, even if it's short, like 10-15 minutes, it's enough to affect the night, right? So that would be a change that someone would highlight for you. And then obviously, as I said, identifying medication that would be very specifically affecting your sleep or that would be needed to help you with your sleep. You might have underlying issues like for some reason there is an aggravation in the depression or your apathy or these symptoms which more complex, or the fatigue is not letting you sleep. So I think it will really highlight how important it is for you to share these problems with the professionals. And sometimes if you don't have access directly to the doctor, share with the other professionals that you may be with, because hopefully if they are dealing with Parkinson, they will know how important this is and maybe can give you tips and tricks about how to move forward. So I hope I've managed to convince you that it might be important to share that. And now let's think about, okay, so if I am going to have these discussions, what should I be saying? It's like, just I don't sleep well is too basic, right? So let us think what people shared with us about what would be most relevant for you, for the group that's here with us, about monitoring your sleep. And the top 4 were: my trouble staying asleep during the night. As you could see in the reports initially, it was very common for people to say that during the night they wake up and then they're not able to continue asleep. Then the next one was waking up frequently during the night. So this comes into fragmentation of sleep. And then we had difficulty turning around in bed, which can be also quickly related to Parkinson. If your medication is not working so well, you will have more difficulties, you'll have more rigidity, and during the night people have less medication as well. So it's like it's adding on the difficulties during the night, which is a shame. It's like it's when we need to be more rested. And then we also had, as something that people were highlighting, which was a fluctuating vigilance or drowsiness, and so the impact that it has during the day and the need for people to have short naps, or hopefully short naps during the day to be able to recover. Many more are there, but just to highlight what people were reporting. And because when we think about, I'm going to have to talk about this topic, it would be interesting. We thought it would be interesting for you to know how are the scientific community and the medical community and the health professionals looking at sleep. So there are typically three main areas where we will put these problems that you report. And the first one is insomnia, which means sleep fragmentation. You're waking up several times during the night. And it's usually reported by this: I wake up and I can't sleep again. This is the most common sentence that we hear. And in Parkinson's specifically, the staying asleep during the night is the most challenging one. So not so much, people usually tell me as soon as they put their head on the pillow, they fall asleep right away. But then it's waking up at 3-4 o'clock in the morning and not being able to sleep more. Now I want to go through with what a typical night might look. By typical is most commonly how people report it. Let me see if I can get my laser on so I can guide you. Let me know if you see my red laser. Yes? Mm-hmm. So here I wanted to highlight, as I said, people might have dinner. So this would be American times, 5-7 o'clock maybe. And I wanted to reinforce this, that after eating, usually we have more drowsiness, right? We get sleepy. And so there's a tendency, if we're more stopped here, that we might actually have these sleepiness and sleep attacks, or what we call it. So imagine you have your medication before you go to bed, maybe at 9, and you might go to bed at 10 o'clock, I would imagine. And you have your last dosage of Parkinson medication, right? And this means that this dosage has to last all the way until the morning. So some clinicians, they might actually give you a specific medication here that actually has a lasting effect, so that you can reduce these problems. And one of these problems, you wake up, so the medication usually, imagine for this interval, the medication will work 2-3 hours, 4 hours. You might take it 4 and 4 hours, 5 and 5. This is typical. Maybe breakfast, lunch, and dinner is the most typical one. But you can see there's a specific interval, and then this interval is greater, which means that probably at this time, 2-3 in the morning, 4 in the morning, what has happened is that you have worn out the dopamine, right? So the medication. So what happens? You get more rigidity, you get more discomfort, you might get pain, non-motor issues like that people have reported, like changes in temperature. So what is coming up here? It's the Parkinson, right? I put here go eating. Some people use strategies to go back. One is getting out of bed, going to the couch, and then they sleep on the couch the rest of the night. And for some reason, they can sleep well on the couch. I have other people that tell me I go to the fridge and I eat a yogurt, and then I go back to bed and I sleep well. So it's interesting to see the strategies that people use, right, to be able to, and to share them with others. So hopefully this can give you a little connection of why things might be happening, most typically in Parkinson. What are the solutions that we have for that? There are a lot of non-pharmacological tips and tricks that we will actually touch upon here, but just highlighting that there are pharmacological interventions that, as you can imagine, it's very difficult in talks for us to get specific situations. So we always recommend that this is an option that you have to discuss with your doctor, to be able to have open conversations. Says, I heard this medication that can help me for this problem, once you characterize what the problem is, right? So adjusting the medication during the night, as you can see. So either the doctor can give you something for the night, or I have heard people waking up and taking medication. But again, that goes back to the habits and the beliefs and the clinical experiences of the person that's with you, the movement disorder specialist.
One thing about those meds too, I mean, I think melatonin is considered kind of a natural supplement. There are a lot of people that do discuss using cannabis-related products, and I would just say that's a very slippery slope, and it's something that you definitely need to talk about with the doctor, because you could wake up in the middle of the night under the influence of something like that and increase your balance risk and other problems. And it's still not clear how those influence sleep quality throughout the night. So we didn't put it in here because it's not one of the ones that are recognized by the International Parkinson and Movement Disorder Society, but it is something that I know that's on people's radar.
Yeah, no, good point. So we've covered one main issue, so it's all the problems that are happening during the night. And then another typical area for Parkinson will be dealing with sleepiness during the day. So that means excessive daytime sleepiness, which can be characterized by you have increased need to take naps, for example, falling asleep suddenly while, imagine you just finished eating would be the most common. You don't even need to have Parkinson for that. You eat, you go to the couch, you sit down, and you fall asleep, right? Or you might be in a meeting or in a situation where it's a presentation like this, and you're fluctuating. Well, these guys are boring, and I'm sleeping, right?
Not boring.
So I think I always appreciate this of napping. I think if you are working, it would be interesting for companies to actually have a little time for people to nap. I mean, it's been shown in some models in certain companies, which I think is really awesome. And it's a pity that it's not more covered.
I think it should be a workplace accommodation if you're working, and you may be getting some accommodations for your Parkinson's if you wanted to ask about, for sure, to improve your productivity.
Yes, that's a good point, because in your cognition, your movement, yeah. So it's worth discussing. It's a specific need that I think in Parkinson you can really approach that. Yeah, okay. And there's lots of tricks. Again, we're going to cover that in a second. I would say the most common one in Portugal, it was actually studied here by a research team, which was the effect of using, we use a lot of espressos. And so it's short coffee, and it's like after lunch, we always have that associated to our meal. As a way for us to sleep, to fight against sleep attacks.
It's a tiny
And it
little
was
espresso
actually
coffee.
studied for Parkinson with good results.
No big American style,
No,
huge
no.
cups like I'm gonna have none of that.
Yeah, okay. So then another area which is of high concern, which is this REM sleep behavior. So that means a rapid eye movement sleep behavior disorder. It's a specific problem that can also be not in Parkinson, but it has, I'd say it's one of the most troublesome one, because often people don't talk about it, because you're waking up in the middle of the night yelling, screaming. I have people that tell me that the husband is very worried. My husband is very worried because I'm going to wake up the neighbors. So we live in apartments here, and so they think they're going to call the police. So it can be a very impactful problem that should be discussed, obviously, with the neurologist, because there is medication that can help. And so it's, and I think there's so much stigma around this issue that's why, I'm having challenging here finding the right words. I know people suffer a lot with it, and sometimes, well, specifically in my country, maybe not in yours, which would be, oh, it's the only opportunity that I have to hit my husband. So people tend to make like jokes about it. But I can only imagine the panic of being a care partner and being next to someone that just woke up and put their hands around your neck. I've had people share that with me. And so, again, we will reflect on maybe tips and tricks that you can use to help reduce that. Just be aware that please do talk with your doctor about it. Okay, so if everyone's doing good and everyone's still awake, we go into our final question, which is, okay, so how do we report it? I would say accurately, significantly, what is worth my time? When we were curious to see how people would be already tackling this problem. If usually you write notes on the phone, if you're preparing for a consultation, maybe the day before, oh, let me just make a list here quickly of of all the things I'm dealing with. And so our suggestion is once you get into the doctor, because the lists tend to be big, try to show them the list so they can look at it and maybe they can tackle or respond to the problems early on. They can connect them in their response. But what we can see here is like sometimes we have other people. It's important for the sleep in particular that if you are sleeping with someone, that they are sleeping with someone does not sound good. If you share your bed with someone, that means that that person will have the insight of what is really happening, right? So sometimes I have care partners that tell me that they are writing down what the person is saying. And here's an interesting strategy that I heard last week, which was actually a psychoanalyst doctor who has Parkinson, and he said that one of the ways for him to deal with the sleep issues that he was having was having active dreams, is to actually wake up and to write them down. And he perceived that the dream intensity and the amount of times that he would dream that would reduce. So this is not science. This was really feedback from someone that is dealing with a specific issue. And I find it interesting that he would take note, and might have any worth trying, right?
Yeah, I mean, especially because I mean his background is in like I said, psychoanalysis, and so he has some medical training, but more importantly, I think he's recording for himself. I like those little tricks though, because those personal ones come outside of the journals, and sometimes they can be a nice thing to implement rather than guidelines all the time.
Okay, and I would highlight here as well, so the CPAP, if you are using the machine to be able to help you breathe during the night and to keep those oxygen levels, that there will probably be an objective way to register.
It matches to that, yeah.
So if we think about ways that we can monitor sleep, is one, we have what we call subjective data, which is patient questionnaires and sleep diaries. And I would say this is how people perceive their problem, versus on the other side, which will be objective data. And that means you're using apps and machines to be able to analyze your patterns of sleep. And it's interesting for us to think it's like one is not more important than the other, because if we do use a machine and you wake up in the morning and you look at, at the information, the objective data, the objective, how many hours you slept, for example, but you perceive that you had a horrible night, right? So you can see there's a mismatch between that information, and this might be very, so the approach to treating this has to also be thought out. What am I going to treat? Is it what the watch is saying that I slept, or is it how I feel, right? So in I would say common practice, so someone that has been a neurologist that has been specialized in movement disorders, they tend to use common instruments, and we like to share them here with you because I think it's important for us to understand what the clinicians are thinking. And so this would be the most common way for them to make a triage to see if you've had any sleep problems. And this is part of a questionnaire, which is regarding non-motor aspects of daily life over the past year. Have you had, past week, sorry, it's always referent to the week before you go to the consultation. Have you had trouble going to sleep at night or staying asleep through the nights? So both problems are placed in the same order. And so it's just consider how rested you felt after waking up in the morning. So this is what he's looking for, right? Or him or her are looking for. It's like, how do you, when you wake up, how do you feel? We have, once they have identified or triaged this problem, then they can go and get more other questionnaires that will go into more detail. And for example, this one is one that is used, and you can get these things online, so it's not like it's a top secret. So this is a way for us to triage if there is any risk of you dozing off during the day. And you can imagine like sitting and reading, watching TV, that's particularly normal, sitting inactive in public places, if you're in a car, maybe for an hour, lying down, sitting and talking with someone. Now, when it really gets severe, I would say is if you are eating and then you fall asleep while you are eating. That's there. Once you've identified the problem, the clinicians will try to, because there is sleep doctors, so I don't have to specifically be the neurologist, right? And they can go through different questions that I'm just sharing here quickly, so that you can get a glimpse of. They are asking you all these specific questions. What time do you go to bed? How long does it take you to fall asleep? Does this happen every day? How do you feel when you wake up? Do you? All this information will help create a strategy plan, right? A care plan, so that we are sure that all the behavioral issues, everything that you can do to modify your behavior to make it easier, might work and solve the problem, so that we don't have to go into pharmacological interventions. It's very interesting just to see that how much research is going into this area. Okay, so moving along. If I had to suggest anything, we like to use the sleep diary. I think is the most informative way and easiest as well. So imagine we select one of those problems that we saw in the beginning that you reported, right? And we grab onto it and we write it here on top. We write it here. Okay, I have difficulty falling asleep. That's one issue. I have difficulty staying asleep. And then we think about specific characteristics that we want out of that. Let's think about the frequency and the duration. So is this frequent? Is this happening every night? How many times per week is this happening? How long does it last? So do you wake up at 3 o'clock and then you stay maybe 2 hours without sleeping and then you fall asleep again? So how much impact is this having? So severity is the impact that it has during the night, if you're waking people up, maybe, if you're living with someone, or maybe the impact on it the day, for example. You might think of things that are making it worse. You might think of things that are making it better, which will influence. Or maybe, and consider, when are you taking the medication? So highlighting, understanding, where is my medication in any symptom is fundamental. When was my last intake? And then getting the input of 2 or 3 words, maybe from someone, a family friend, or that can get that information as well about how your night is. So hopefully, I think it's a nice simple way for, if I'm going to write something down, what am I looking for in terms of characteristics? One thing that we do want to highlight in this talk is it is worth us sharing with as many people as we can, because you see how this gentleman shared that with me, and then I share it with you, about things that may help the sleep. And most of the non-pharmacological knowledge that we have is based on that. It's on tips and tricks that people use and things that we perceive that will benefit your sleep. So it's worth thinking about, what can I add on to share with the doctor? You know what? I've already tried this, 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 this. You will save him time from telling you to do it, right? So here we are, some examples.
Well, I think one of the most important things, and I look at this, is not getting wound up before you go to sleep. So turning off the television. I'd say news programs are really not beneficial in the evening. Watching the 10 o'clock or 11 o'clock news may not be the best way to wrap things up. And so things that don't involve screen time are valuable for sure. And then obviously, as part of the nocturia, the getting up to go to the bathroom, things that maybe also influence sleep, like alcohol and caffeine, in addition to liquids. As a speech language pathologist, quite often people come with complaints of reflux, and it actually may influence their voice. And that's one of these issues where, if you're eating food, make sure you have some time for it to digest. Someone getting a little cup of yogurt in the middle of the night, I can look at it and say, oh, well, I don't know how I feel about that, but that's pretty mild. But if you're going to have a big, heavy piece of meat, which will take some time for it to digest, or something that's very fatty or heavy, like fried food or cheeses or something like that, make sure you're giving yourself enough time for that food to digest, because if you get to a situation where you get some reflux, that'll disturb your sleep just as many other issues like apnea will. And this last thing that's so interesting is blue light spectrum, meaning daylight spectrum, 5400 Kelvin. That is what is coming from your screen, and that temperature, as they call it, the light temperature, actually mimics broad daylight, and so it tricks your system, your circadian rhythm, into thinking that, oh, hey, it's daytime, and so it will actually tell your body to produce less melatonin. And that melatonin is what helps you keep asleep. That's why you take it as a supplement sometimes. So for sure, you want to cut the screen time later in the evening. You can get black glasses that block it. You remember those old blue blocker commercials, but there's a number of other computer-based ones that are a little less yellow colored. And so that's a very good thing. And I'll say to anybody, I've stopped taking my phone into when I go to sleep, and I think it makes a huge difference because it reduces temptation for looking at it in the middle of the night, and it also keeps it kind of out of sight, out of mind. So it's very valuable. If you find yourself in a situation where you are awake and you can't get back to sleep, first make sure you log that, because that's going to be something to talk about with the doctor. But don't try to lay in bed and just sit there. I'm going to tough it out. If I'm in bed 15 minutes from now, I'm going to try to do something else. Once you've been up for a little bit, changing position seems to help. And again, a lot of people talk about going out to the couch, or they have a nice recliner. That seems to help. Or you can try to do something that's relaxing. It depends on whether or not turning a light on is going to do something to your ability to get back to sleep. It's different people have different things. Again, drinking at night, we were talking about that before with alcohol and caffeine. For sure, those will influence your sleep. But also, just drinking water. If you get too much of it late in the evening, you're definitely going to have more trips to the bathroom. Now, as we all age, a single trip to the bathroom at night is not necessarily problematic. If you're getting to the point where you have more than one in a night, that's probably something to talk about with the doctor, because there are actually clinicians, there are pelvic floor specialists and other clinicians that can actually help you address that issue. And then, of course, just like everything else in the world, exercise is going to help your sleep function. And there's a number of studies that show that regular, vigorous exercise improves your sleep quality over time.
Yeah. Yes, so this is just an example. I mean, there's there's a limited amount of studies already doing this association with exercise and sleep. But it's nice to see that you can get into details of, sleep efficiency, wake after sleep onset, total sleep time. So people are really, and I think it helps obviously having these objective measures to be able to do these type of studies. So the summary here is that we can go into more depth about what part of sleep are we actually helping with the exercise. The question now is what type of exercise will influence sleep, and that's the next phase I would imagine for research.
It's nice that it's a real RCT. That's a big deal. That's a real study. There are things you can do called cognitive behavioral therapy you can do to unwind and to calm the thoughts, and especially for people that have the kind of insomnia where they can't fall asleep because thinking a lot of thoughts and then the thoughts are racing, or if you wake up and you can't get back to sleep due to some anxiety. So cognitive behavioral therapy really is just a way of kind of very rationally talking through the problem and getting rid of kind of the worst case scenarios and really reframing things with ways that are more positive. And it's not rocket science, but it's nice to have it. Now you can do this with a clinician for sure, and that would be the best, but this is a nice little app that's freely available, put together by the Veterans Administration, called CBTI. Again, more sleep hygiene. I think it's valuable to have complete darkness. It really helps. Light pollution will definitely influence your sleep ability. You can also add a sleep mask in there if you don't have the ability to completely shut off all the light. You do want to have a way to get to a light source if you need to get up in the middle of the night, or you're going to have night lights available, but you don't want to be walking in the dark. That's a very big risk for falls. That's when a lot of falls happen.
It's not only the darkness and the effect of when we shut our eyes, our balance is compromised, right? With or without Parkinson, this happens. But it's also a period of the time where your dopamine, where your medication is not working so much. So everything is added on to make it such a risk situation.
And that's also why we were talking before about medical marijuana. Your dopamine's at a lower level, your balance is impaired with the lack of light, and then you add in a third confounding factor, which would be the changes in balance, vestibular changes due to the marijuana. So this is why you want to work through that with your doctor.
I think one compromise, changing the environment is also an option. So, just making sure that your bed is closest to the toilet as possible.
Mm-hmm.
Okay.
We've even had people use,
Yeah, I was thinking about other options, but it's so personalized.
Yeah, that's a doctor or really a clinician working with your OT or your PT on that.
No, and it makes me think about there was several here. I'm talking about someone that's pretty young. She's 43, and she during the night when she wakes up, she has severe pain in the foot, and so she actually can't walk to the toilet. And so and her husband wants to carry her. And as I'm talking about someone that's 43, right? Me as a professional saying, why don't you use a wheelchair, for example, you can see how aggressive that recommendation would be, right? So it's like, how can we help people with maybe strategies that are more human for that situation? So it was a complex situation because she knows the husband insists on carrying her, in his arms, and this can only last as long as possible. Sometimes when he's really asleep, she's actually crawling to the toilet. So it's very dramatic, as you can see, right? The situation. To finding solutions of having something close to you. It seems like good sense. Professionals have great ideas and recommendations, but sometimes for that person, that age, it might not work so well. So just keeping mindful of this, because we are talking to a recently diagnosed, and then sometimes you might hear things that you might be a little bit against, but make sure you share that with the professional so we get that knowledge, right?
Yeah, no-go zones. I kind of love this solution because you can have satiny sheets, you can have satiny pajamas, things that are not like anything that's going to have any kind of cling to it is not going to be valuable. But you can overdo this. You can have too many things made out of satin at once, and then you're too slick, and all of a sudden you're sliding around in bed or having a hard time.
Yeah, I usually recommend either you have the lower sheet or just your pants with what do you call the type of cloth?
Oh, with satin or
Yeah,
silk.
yes.
Yeah.
That might facilitate, and this is not an issue of later stages. No, it's not. This is a difficulty about turning in bed, and that can affect anyone, and it will also make the comfort of your night. You'll have more rigidity because you're not turning so much, right? Because you're staying in the same position a long time. So it's worth using. It's a simple trick.
Oh yeah. Anything you can get these days. And if you really are having that kind of bed mobility, I mean, you work on that all the time with a PT, so you can also work with a therapist to address some of that as well. I think of this last slide here, last section, I mean, a comfortable bed, obviously. Sometimes you have to be real careful that it's not too squishy and supple. Appropriate lighting we get into there, but room temperature is a huge factor, and so making sure your room is not too hot. It seems like a slightly cooler temperature helps people get to sleep a lot easier and stay asleep.
And it's a tricky one as well, because your husband or wife is basically they have temperature needs that are different.
Yep.
And so I often see the fight between both, which is I'm trembling with coldness and he's hot, and just so eventually we'll have to think about these double beds, how can we separate the clothing, I think.
Yeah. Sonia put something in the chat here, and I think it's totally apropos. Someone in one of our groups, they found a regular sheet with a satin patch, so it's only slippery in one spot. I think that's a very elegant solution. It's got the sweet spot or something like that, so you can get around. So that might be something to look at.
They should pattern that as sheets for Parkinson,
That
right?
feels like an OT thing with that, but maybe I'm wrong, just because they're such MacGyvers.
Yeah. But cool. So some of these things are going to be really obvious, right, to you. And again, when you with the doctor and you're sharing, I have these issues and I've tried this, you're going to spare time of them stating the obvious. Yeah. Here's some more.
Yeah, I mean, daytime sleepiness is another really common concern, and so you want to be really vigilant. If you have eaten something, especially if you've eaten something that's going to require some processing, so that's usually a complex carbohydrate, or meat. Avoid driving after lunch, after meals, and at nighttime. Nighttime has its own particular issues too, with some of the changes in vision and contrast sensitivity, but it might be a situation too where you have a sleep attack. Joseph is really good about this, about avoiding any kind of naps or early evening naps, because you don't think about it, but a 15-20 minute nap later in the afternoon or evening could basically throw your whole cycle off. Now, if you got something regularly scheduled, you've worked it out with work, or you just know when you're doing it, earlier is better, that might be a different story. And actually, even right after a meal might be a different story.
Yeah, so I'll have often people telling me that I take a nap, and it's like, how long do you do it? Oh, I sleep about 2 hours. Like 2 hours?
Yeah.
This is obviously someone retired, right? Um, but it's worth thinking about how long your nap is as well. There have been some studies, 20, 30 minutes will not affect your sleep.
Yeah. I just looking at the chat here. So another person put in here a company that makes sheets and pajamas for people with Parkinson's called Comfort Linens. Okay, so this is it's not a podcast, but here's our plug for them, because if it's made for people with Parkinson's, I love it already.
Yeah.
So Comfort Linens, you can look them up online.
I'll look it up. Yeah,
That's very good. Thank you for sharing that. That's great. That's I love that part of this group, is that we can get a lot of insight from people.
Yeah, and then you have the coffee, as I said, has been research based. So,
and this is one of the things, though, during the day after lunch, sometimes some people might find after 1 o'clock it's too late to have more coffee. So if you find that maybe the coffee is influencing your sleep later on, then I don't know how you'd say that to someone in Portugal, but you could.
Yeah, this is specifically like a sleep attack. Like someone says,
Yeah.
I'm a driver, and I'm driving all the time, and after lunch, so this would be almost like a pill, right?
Yeah.
So it has to be used with caution, because you put other things into equation, which is if you have some challenges with your heart as well, so you might want to consider consulting your cardiologist about it as well.
Sure. Oh boy. Yeah,
So stuff like that. It's just, as I say, get guidance from the professionals. That's why they exist.
Now, there's other techniques. I'm going to address this in a second, but the CPAP, the continuous positive airway pressure, is specifically for people that have sleep apnea. So you need to get a sleep study and get diagnosed with that. But the people who have had that specific issue, you might be able to address it also by losing weight, but oftentimes the CPAP is an adjunct to that. But they say very good things about it. It's like a miracle that changes things overnight, because it provides so much better quality airway that they get better sleep at night.
Yeah, the feedback I get is just so difficult to use.
Yeah, and if you have any kind of noise sensitivity, your spouse has a noise sensitivity, I think that it's an issue for that, for sure. But they have come a lot long. It's like hearing aids in some way. They've come a long way in the past 5-10 years. So if you tried one before, or if you remember one from a family member, and you're like, there's no way I'm putting that thing on, I'm not going to look like Darth Vader. They don't look like that anymore. They're much better. So worth considering, especially if it can be, like so many other things in Parkinson's, there aren't a lot of quick solutions. This could be one, just like a vision check and eyeglasses and hearing aids could be very, very dramatic improvements quickly, and it's worth looking at. This timed light therapy is I love this approach. I first saw this in 2016 at the Mood Disorder Society conference in Stockholm. There was a researcher at that time at Rush who was just using off-the-shelf daylight spectrum lights during the day, and found that short times, 20 minutes at a time, was improving alertness and daytime sleepiness. Now that's going on and been now Sonia brought the link in here for Comfort Linen, so now you can find it in the chat. But now this timed light therapy, Dr. Vidanovic's work, has now been refined, and there's actually a study going on right now with a Celeste study, is what it's called, and they're using a very carefully calibrated light therapy approach. And so actually I should have brought it in here, but you can use that light therapy, and it's non-pharmacological, it's non-invasive, and it might help your alertness, and so it's kind of nice. Okay, now if you're someone who is moving around a lot, if you have REM, sleep behavior disorder, and there are people who have RBD without having Parkinson's, and it seems to be a high risk for turning into Parkinson's or something like it later on. So they've already dealt with this before, but you can find ways to protect your environment. So the first thing is get your bed against a wall so that you can't fall out at night. You might put pillows around it, or even one of these little rails that you can bring into the side of it. You could slide it in there. If you're really thrashing about, you can even sleep inside of a sleeping bag on the bed.
That's one of the ones I liked most, I think. Yeah. And I wouldn't zip the whole thing up, but just halfway would be enough to control maybe the agitation.
Yeah, you're not trying to make it impossible for you to get out in case you need to go to the bathroom. In extreme situations, you move the mattress onto the floor, so if you do fall, you're not adding an injury. So that's another way to do it as well. Futon or something
Or
like
at
that.
least the carpet floor, which
Yeah.
I think is more common in the US, which is great. We don't have it so much, so but I think just thinking about that, it's often that people say they sometimes fall out of the bed. Okay, so we had ways for us to assess it subjectively, and now objectively there are tools that can be used.
Yeah, and just go back real fast. Make sure that the gold standard we know is a sleep study with a sleep specialist, and your doctor may recommend that, and you'll go into a place and they'll put you up with a bunch of wires. That's the gold standard. And if you're trying to really dial in on a real sleep events, that's a great opportunity to learn a lot. So don't fight that. That's a very good thing to consider. In lieu of that, if you're not actively dealing with something that's at that level, you can use different apps. And this is one I like to recommend a lot. It's called Sleep Cycle. It uses the microphone for monitoring, makes it into like a micro radar device. You do have to place it on a nightstand that's within range of you. You can't have it, charging in another room or down on the ground. It has to be up in the right position. Provides pretty interesting, accurate sleep data, and it does it in a very non-invasive way. The newer versions of the Google Home, the Google Nest, formerly known as the Google Home, they also have this technology. Same caveat, you need to make sure it's in a position, but if you have one of those, you can upgrade it, and it's kind of cool, especially because you don't have to have a wearable. I, I, I'm not against wearables. I used to be a little bit more frightened of them, but actually, more recently, the Fitbit has come quite a long ways, and they've improved their sleep monitoring capacity. They've tuned it to some medical level EEG machines, electroencephalograms. So if you have a Fitbit, you might consider putting that on, and it's pretty convenient. There are other wearables that you can use, and they're not quite as open. They're a little more opaque with their data, but they probably are able to provide you with some basic information about how long you're sleeping, when you're waking up. So the Apple Watch, the Whoop Band, the Oura Ring, and my only thing with the Oura Ring and the Whoop Band is that they almost always have a paid subscription, where the other ones maybe you don't have to do that. So that might guide you towards one or the other. But it's pretty nice. And the ring, what I'm showing you, it actually fits on there like a ring, and so you don't have quite the big form factor that you have for some of the other ones. None of these are going to be as good as a polysomnography, like in a sleep lab, but they could highlight a problem. They could help you get some information. And for those of you who are like, I don't really want to log everything every time, it's easy enough to look up in the morning, and then you can just take a couple notes, and it's not so much effort. Or I like the person who mentioned, I have a notes app on my phone. I put it right in there. You can send yourself a text. You can do a lot of things with that. But it's nice to just paper and pencil it and have something to back you up.
I would imagine this be more useful to like monitor if you're having some sort of crisis situation, so just monitoring. But taking all this data to the doctor, you might be a little bit overwhelmed with it, as you can imagine. Remember, he's always going to treat, for now, best practice is to ask you how you perceive your sleep. So it comes back to how do you feel in the morning. But again, this technology is going to help us. We have to use it in a wise way in order for it to be truly useful.
I think that's a super important point. I mean, you have limited time with the doctor, so if you come in with 97 days of Apple Watch data, you're wasting both of your time. You need to use that data to give you insights so you can ask better questions to the doctor and break it down. And that's great insight.
Mm-hmm. Okay, so our take-home message for our talk today is really about making you aware that communicating your sleep-related issues and concerns, and also the strategies that you use and the tricks that you use. So if you can share that, it will also be very useful so that you can get more quality of care.
Yeah.
Okay, so we will finish here and stop the sharing. So if you
any questions,
let's just check the chat and see if there's something specific that we haven't covered that can be helpful.
Yeah. Feel free to unmute. You can type it in here.
Let us check if everyone's awake.
Yeah.
Yes.
Got my finger.
You have a question, Corten? Yes?
Not really. It's a great presentation. I'm wondering though, like, um, I've had Fitbit since about 2015. The worst, what do you call it, information that I get from that, it's not the exercise, it's the sleep. It'll tell me you slept an hour and 45 minutes. And I'm like, I've been in bed from 10 to 6. Come on. So I don't know if there's a better one out there that you can suggest or recommend.
It's so interesting you say that because about a decade, about around that time, 2015, I was part of a paper outlining some technologies, and I wrote part of the section on wearables for sleep monitoring. And I had said that I did not believe in what's called actigraphy, and Fitbit was one of our use cases, and so we were not recommending it. But since then, Fitbit has actually contracted with a medical grade EEG to validate it. So you might consider doing an upgraded Fitbit if you haven't had one in the past couple of years. And if that's the case, you have done that recently, then perhaps you just need to get a better project out there. Maybe you try something different. Um,
My last one was 2022.
okay, so you have the one that looks like an Apple Watch.
Yep, I don't know if you can see it, but
Yep,
yes.
yep, yep. Well, then I'm just going to say that I think that maybe that's not the device for you. And again, different people, the perfect world, you could go in and have it calibrated to a real device. And unfortunately, I don't think that business model exists yet. There, you might try a different one. You might try like if one of the free apps like the Sleep Cycle and see if you could calibrate the two to there, and then decide maybe that's better. And that app is free. There's a paid version that gives you more information, but you could just try the free version on your iPhone or your Android, and that might be a better start.
Thank you for doing all your research for us. I
I,
appreciate it.
I was one of these things where I was actively telling people Fitbit's terrible, and then all of a sudden it's like, oh, okay, I'll revise now. So if you saw this lecture 2 years ago, I probably should go back there like Fitbit is wonderful. Right? Someone was asking about that study. I'm going to find it on the sleep
Yeah.
one because it's
Well, it's interesting that you validate that question that I was saying. It's like you wake up in the morning and you feel really
Mhm.
good, and then suddenly this thing tells you you've only slept an hour. So,
Exactly.
and
So, I can't really say go get a Fitbit. Oh, by the way, it's now owned by Google.
well, that's another issue, isn't it?
Mhm.
Everybody's data. One thing that Fitbit does allow you is it lets you into all the data. Um,
Yes.
and of course you got to go in there, and it's not easy, but
No.
it's many of the other ones are much more opaque, and like a Garmin and the app
Hmm.
in particular, you can you get what they tell you, and you'll like
It's
it.
true.
Yeah, yeah,
I like being able to kind of program it a little bit. So, thank
yeah.
you,
Thank you.
John and Josepha.
I mean,
Yeah, thanks for coming in, Cortha. I mean, and good insight. Again, when I see it again, I'm gonna be like, well, I've heard from somebody that they told her that she was sleeping 2 hours a night, and she's not.
Exactly. I think the most I've gotten it to register was 3.
And there's actually no good devices that can measure daytime sleepiness. If people falling asleep a little bit
True.
during the day, it's
yeah.
it's like it only measures it when you're in the position of sleep. So you gotta the accelerometer has to be in the right position, or it's
Or
like, oh,
if
you're still
there's
awake.
maybe a hand or a fist, that comes across and hits you in the shoulder when you're sitting at the wheel at the red light.
Yeah,
Wake up.
that's an Uber thing.
Okay. So we
Thank
have here comments in the chat.
Someone is tossing in
So
pain.
maybe we'll just read it out loud so that we can comment. What if someone is tossing and turning in pain for hours and does not get to sleep till 4 or so
you.
in the then cannot get up the next day till 12 or 2? Still exhausted and has had pain injections and is taking fast and long-acting melatonin 5 milligrams. Okay. Also not exercising now, much due to the pain. So from what I'm understanding, it's the person goes to bed and in bed suddenly you have pain, or are we dealing with pain before going to bed and then it's not, and lying down does not take away the pain? So I think the way that I would suggest is we have to understand
Come again.
where's this pain coming from. Is it related to the medication or not? Because you can have things like the cramps and the dystonia, which is contracting, which is can be very painful. And because if it is related to the medication, then the adjustments will really pass through your movement disorder specialist, the neurologist. So if imagine it's related to musculoskeletal pain, which means related to the muscles, the rigidity, if you're not exercising. So I've actually challenged people to do different types of exercises before they go to bed to see if that would somehow influence the rigidity and the pain during the night. Because I was intrigued about suggestions of doing soft exercises or doing more aerobic exercises. We don't have a strict answer, but from my perception is doing mobility exercises, which means big, not necessarily fast and aerobic movements before you go to bed will control the rigidity throughout the night and might help. But it would go back to trying to understand what type of pain are we talking about and what you have tried. I've seen injections as well, is written here.
Well, and my question would be also, if it is pain related to the Parkinson's, I'm hoping that everyone here is working with a movement disorders specialist that's a neurologist with fellowship training, so additional training to specialize in Parkinson's related disorders, just so that that doctor that's giving you their advice has the knowledge that if you can have fluctuations in pain due to the medications wearing off. And so if you're going to a doctor that doesn't know that, that's the first thing I would try to correct. And then if you still have the pain, maybe you have other sources of pain, then what Josepha said about exercise and maybe working with a physiotherapist to address that pain. And then if that doesn't work, then that doctor may wish to refer you to a pain specialist, and there may be a different set of medications that you would take. But I wouldn't go to a pain specialist without working directly with a mood disorder specialist, because there are certain medications that are contraindicated for people with Parkinson's. But it's one of these things where, first part of that, if you're just seeing a community doctor or even a community neurologist, maybe step it up, just even a consult with a movement disorder specialist. But if you're already with a movement disorder specialist, then it's like, okay, could I address this with a physical therapist? Okay, can't do that. Okay, could I address this with a pain specialist who is collaborating with my movement disorder specialist? A lot of specialists, but that's America. But anyways, that's what I start with.
Yeah, if you don't have, we have these tips and tricks here in Portugal. And so I would probably just like, that is a long time to fall asleep in pain, right? So
that sounds terrible.
And so it's like trying to figure out things that might alleviate. And I know this will sound particularly difficult, but because I don't know the situation, but for example, a warm shower before going to bed might reduce the rigidity. It's a lot of struggle because you have to undress and dress and take a shower and head. So logistically, it might not be the easiest recommendation, but if that reduces the amount of hours that person falls asleep, it's worth trying.
Let me just see that it came on yours and come to mine there. Yeah. Can we please explain more about RBD, and can you fix it, or will you have, okay, so can you please explain more about REM sleep behavior disorder? What is it? Why do people get it? Can you fix it, or once you develop it, you will have it permanently? So the RBD itself is a phenomenon that's highly associated with Parkinson's. Some people never get it. Some people get it later in the diagnosis of the disease. You might have it for a number of years and you'll start to get it, which is another reason why you want to monitor your sleep, so that if you see the beginnings of it, you can let your doctor know. And then some people, as we mentioned, can have RBD for many years before a diagnosis of Parkinson's, and they're highly likely to get it. So now, can you fix it? Well, yes and no. You can definitely do things to improve it. I think the first thing, if you're in the early stages of it, I would be trying to find ways to non-pharmacologically improve my sleep, and I would start with exercise as well as the other, like the bright light therapies. But then working with your doctor, there are medications that you could take that will also improve the sleep and reduce that. But those medications are very specific, and we're not doctors, so I don't want to recommend it. I want you to have a conversation with your movement disorder specialist. I have to say that most people who have it at some level ongoing. It's not something that you're going to take an aspirin and it's gone, but you can definitely mitigate it. Is that a fair answer? It's a Parkinson's answer, which means yes, but no, but yes, right? But you can definitely address it. Just make sure you're working with a movement disorder specialist because they're really going to have the breadth of experience and the firepower to really address it properly.
I think the kind of stuff, if it does happen, there's ways to control it.
Yep.
If it stays, we don't. It's not useful to say yes or no.
Yeah, but you can definitely
like,
address
here
it.
comes another problem and it's going to stay with me forever, right? So I think trying to control the amount of symptoms that you hear about Parkinson might be useful.
Yeah, taking it. Okay. Okay, let's go down a little bit. Okay, you've been seeing it's just the wrong size. Okay, been seeing movement disorder specialist for years. Has an appointment in okay, good, this month, later in about a week, and seeing a rheumatologist and an orthopedic doctor. Okay, so yes, this individual who has the pain, that's another thing. I think a rheumatologist is a very smart referral because this could be a systemic pain syndrome. And it's interesting, if it is rheumatoid arthritis or something like that, a lot of the medications for the TNF inhibitors actually have some benefits for Parkinson's. So it's a win-win. You can't stop taking the Parkinson's med, but it'll be a benefit for sure. And then, yeah, you might look at orthopedic doctors. Before you consider a surgery, though, you'll probably work with a physical medicine and rehabilitation doctor that's a PM&R or a physiatrist, and they'll probably help you identify the true source of the pain working with your movement disorder specialist, your rheumatologist. Again, we love our specialists in the United States. We like, hey, have you seen this specialist? Have you seen the eyebrow specialist? It's like, but that PM&R doc will help you diagnose because you might have good luck working with a physical therapist, especially a physical therapist that does some of the manual therapy, and you might find ways around it, although surgery can be very beneficial.
This is a very specific pain, which is in lying down position.
Yeah.
The pain is not going away, right?
Yeah.
So I would look into that because it's one thing when I'm walking and I have pain because I'm using my body in the wrong way, and usually people, oh, as soon as I sit down, I have no more pain. And it's like having pain in the lying position is something to really research and understand why. Okay, everyone.
I know we've gone a little bit over, but we're happy to answer questions. So maybe that's anything else? Yeah.
We hope you found this useful. And yeah, the materials will be available for you to then go back to and see the strategies that makes most sense to you.
Yeah, so everything will be available. The links and the slides for downloading will be on the ipmdc.org website. That's the Inova Parkinson's and Movement Disorders Center website. Sonia has them all cataloged there, and you'll be able to capture them. And you can certainly follow up and ask us questions, or if you get them to Sonia, put it right there. You're awesome, Sonia. You can put it right there and give her an email. She'll get it to us. You can send us an email. We'll answer whatever we can. And be sure to talk about it with your doctor. Your movement disorder specialist has a lot of answers. So, okay, thank you for coming in. Thank you so much for saying that. It's very nice of you. We'll see you next time. Thank you,
Thank you,
folks.
everyone. I hope you get a nice sleep tonight.
Yeah.
With some strategies, no tricks.
All right. See you, folks.